Join me as I welcome Dr. Qasim Ali Butt. Thank you.
Thanks, Brian. Thanks for the intro. You read my entire CV. I really appreciate that. And you know me better than I know myself, apparently. So thank you for having me, guys. I really appreciate it. Guys, I'm Dr. Qasim Butt. I'm going to be talking to you all about kidney care in America. I'm involved with kidney care in the United States for the last 11 years in private practice. I'm going to talk to you about the challenges and potential that are there, and especially the inefficiencies and problems we have. And what's great about being here at Triple Ring Technologies is that you guys are into the solution. So hopefully, whatever I come up with, the challenges I face and show you, perhaps you guys in that field in medtech can come out with solutions for that. Okay. Now, I'm just going to go over myself again. He kind of gave me a good introduction, but a little about me, who I am. I am with South Texas Renal Care Group. I've been there 11 years. I'm a partner with that group. I'm both clinical and interventional. So clinical means I do clinical work as far as see patients in clinic that have kidney disease, see people on dialysis, and see people in the hospital. But I also am interventional. So I do procedures. So, and particularly those procedures go on dialysis access in people's arms and things like that, and catheters in their necks. And I'll go over that a little later. I've had various leadership roles, like Brian went over, a chairman of medicine. I've been board member of the Texas Kidney Foundation as well. Well, in the last few years, what's cool is I've gotten involved in social media, creating online video content that's kind of easy to understand for patients, 2 to 5 minutes long, kind of have a little fun with it, joke around. But also try to educate people on their terms, using their language that they can understand. I've had various public speaking roles as well too. I've educated about kidney health around locally here in San Antonio to local populations here, but also have done education for nurses, nurse practitioners, and doctors. And over the last few years, I've gotten involved with value-based medicine. I've been asked to speak here at university about value-based medicine and the kidney care models that Medicare has come out with. As Brian mentioned as well, too, I've gotten, in the last year and a half has been a real cool ride for me. I've gotten involved in the med tech startup world with Aleo, which actually was incubated right here at Triple Ring. Great company, great founders. I love being involved with them. Icona Health, which is involved in kidney disease education, digital platform for that, and Doctorpedia, which is actually a platform that creates online video content for doctors and education for patients as well. And as you mentioned, I did the AI and healthcare course at MIT recently. It was just really awesome, gave me a lot of insight. And quite honestly, in the next few weeks, I'm actually leaving my physician practice, leaving clinical medicine in pursuit of healthcare technology and healthcare startups as well. I'm actually actively looking for opportunities at this time. I know I've been told that there's a lot of students involved here. And just so you know, you're a 20-year-old student, you look to us as adults and say, you guys know what you're doing. But honestly, none of us know what we're doing, and we're all along for the journey. So I'm happy to be here with you guys, especially the students. So anyway, and full disclosure, just so you know about me, occasionally I do tell inappropriate jokes, guys, inappropriate jokes. Occasionally, I know ever since 2020, jokes can cause PTSD, but I promise not to go full Dave Chappelle on you guys. All right, so just so you know. Now I've been at it for 13 years, 11 years in private practice, 2 years in training. And what words would I use to describe my industry, kidney care in this country? Well, one would be fulfilling to a degree, two, stagnant, and three, inefficient. And that's been my frustration in the industry and kidney care as a whole. And I'm going to go over that. But what's the problem? What's the problem here? Why is our industry like this? Well, the problem is, it's the most expensive disease y'all ain't heard about. Okay. Most of you guys have heard of cancer, and most of you guys have heard of heart disease, right? You guys know those diseases, but you've never heard of kidney disease. But the fact is, kidney disease is expensive. Okay. And in 2016, Medicare fee for service spent $114 billion to cover people with kidney disease. $114 billion. That's one in every $5 Medicare spends goes to people with kidney disease. That's pretty dramatic, right? And Medicare is an interesting relationship with kidney disease because it actually pays for dialysis. And I'm going to go over the coverage a little later. Okay. So let's start off with the basics about kidneys and what they actually do. Okay. So the kidneys are essentially just a pair of vital organs. They're bean shaped and about the size of your fists. Okay. They sit in your back region. You guys all know that. So you have two of them, right? Now, what they do is in a day, the kidneys actually sift through 200 quarts of blood to produce about 2 quarts of waste products and extra water in the form of urine, right? Now, the kidneys are always making urine, right? They're always making urine, but they're connected to tubes called ureters that drain that urine into the bladder. Now, I want you to remember, you're always making urine. You only urinate when your bladder gets full, and that stimulates you to actually urinate. Okay, so kidneys are always making urine. It's just stored in the bladder. What do the kidneys actually do though? They do more than you think. Okay, they do way more than you think. And I always say that the kidneys are the most underrated organs in the entire body. Okay, well, one, they remove waste products from the body. They balance all the electrolytes, the sodium, potassium, phosphorus, all that stuff that's found in Gatorade or Powerade. That balance in your body is played by the kidneys. Okay, they remove drugs from the body. They balance all the body's fluids as well too. So if people with kidney disease oftentimes develop swelling in the legs or develop fluid in their lungs, they release hormones that regulate blood pressure. They produce an active form of vitamin D that helps with bones, and they control the production of blood as well too. They actually secrete a hormone that helps your bone marrow make blood. So they do a lot more than many of you even knew about, right? But what I want you to take away today is that they're a filter. Right? They are a filter that clean your blood, okay? And they do all those other things. Now, as far as you guys in the medtech community, there's two types of kidney doctors out there. There's a nephrologist like myself. I'm in charge of the kidney function. I can use medications and do dialysis. There's another type of kidney doctor called a urologist, right? That's actually a surgeon. They handle things like cancer, stones, prostate issues, and urination issues, okay? Now, the way I like to think about it, nephrologists, we handle the kidney function. The urologists handle the plumbing, okay? So any plumbing related issues, you come up with a device that's related to plumbing and drainage of urine, that's going to be more on the urologist side. Kidney function and dialysis, that's more on the nephrologist side, okay? So what is kidney disease? What is it? You've heard the term. What does it actually mean? Well, the proper term is chronic kidney disease because it is a chronic disease. What's defined is when the kidney function is decreased for over 3 months or longer. Okay, so 3 months or longer of having decreased kidney function and or having a marker in the urine. And that marker typically is either having blood or protein in the urine. So that's a sign of kidney disease, blood or protein in the urine or a decrease in function. The kidneys are actually a giant filter, but they're made of tiny microscopic filters called nephrons. Those are the tiny filters that are attached there. And the kidney disease acts by slowly destroying those nephrons over time. And we have so much excessive reserve capacity that by the time you discover kidney disease, it's oftentimes later on because so much tissue has already been destroyed. Okay, and usually kidney disease attacks both kidneys simultaneously. I get that question all the time from my patients: which kidneys working, doc, or which one, the right or the left? It's usually both. Now, you can't have a stone in one kidney, you can't have a cancer in one kidney, but typically both kidneys are attacked simultaneously whenever you have kidney disease. Okay. Now, kidney disease is a serious problem. 37 million Americans have kidney disease. That's about 14% of the general population. And as you get older, you're more likely to have kidney disease. If you're over 60 years old, there's about a 25% chance you have kidney disease. And it disproportionately affects older and certain minority groups. You can see here by this graph, if you're over 65 years old here, you're going to have a higher chance of having kidney disease. Men and women are a little slightly equal, the women a little bit more. But for the most part, as far as race, Blacks and Hispanics are more adversely or more routinely affected by it than other populations. As far as detection, how do you know you have kidney disease? Well, first off, do a blood pressure measurement. People with kidney disease will oftentimes have high blood pressure. You can check the urine, and when your urine, again, you're looking for either blood or protein. That's a simple screening tool you can use as well. And then you can do a blood test called blood creatinine. That's the marker in the blood that we use to actually determine kidney function. And that blood marker is taken and then put into a calculation called EGFR. EGFR is the estimated glomerular filtration rate. And that's how we kind of calculate it out. Okay. So that blood calculation, again, the EGFR, you take the blood serum creatinine, you put in a calculation with age, race, gender, and other factors. And that GFR will tell you how much kidney function you actually have. Okay. Another way to tell how much kidney function you have is do a creatinine clearance. Okay. Creatinine clearance is actually a collection of 24 hours. Yes, you collect your urine for 24 hours, and it gets worse. You have to put it in your fridge and keep it cool. Okay. So you actually collect your urine for 24 hours. That gives you a proper assessment but it's so cumbersome. A lot of times we don't do it. So oftentimes we just rely on the EGFR, the blood test, and that's what we go off of. Now, the EGFR, the normal EGFR is 100 or greater typically. That's a normal EGFR. But for sake of argument and for sake of simplicity, the way I explain it to my patients, I just treat EGFR like a percentage of kidney function because the normal is 100 or greater. Just to explain it to patients, when you come to my office, I'll be like, you have 35% kidney function, 40% kidney function, just so they can relate to that term. As far as kidney disease itself, it comes in 5 stages, y'all. 5 stages, 1 through 5. Okay, 1 being the least, 5 being the worst and most severe. Okay, 1 is when you have kidney disease, not more than 90% kidney function. 2 is when you have greater than 60% kidney function. Stage 3 is between 30 and 60%. It's kind of a wide-ranging stage. Stage 3. Stage 4 is between 15 and 30%, and stage 5 is 15% or less. Now, when you have 15% or less and you're in stage 5, that's called end-stage kidney disease. That means you probably need dialysis at that point, okay? And the way it works is that there's a disease progression. You start off with 1, then 2, then 3, then 4, then 5. And then eventually when you progress, you need dialysis. You have end-stage kidney disease. You're going to see this term ESKD or ESRD. They're kind of interchangeable. It means end-stage kidney disease. The inherent problem in medicine right now is that we get the referrals late. We get the referrals typically at stage 4, late stage 3 or 4 or 5. So we're getting them late. So when we get them that late, there's not much we can really do as far as progression. We've got them when they're so far along, okay? Now, as people at increased risk, as I mentioned, older, diabetic, high blood pressure, people who have family history of kidney disease are more predisposed to it, and people in certain ethnic groups, as I brought up before. As far as symptoms, this is a silent killer, okay? Typically, people on early stage kidney disease have no symptoms. Okay, the way I like to explain to it is by the time you have symptoms, it's too late, right? By the time you're having chest pain, you're having a heart attack. By the time you feel the mass, you already have cancer, right? So when the early stages, people oftentimes deny, I feel fine, I'm urinating. What's the big deal? But in early stages, there's no signs or symptoms of it. Late stages, typically when you're in stage 4 or later, is when you really start to have symptoms, issues with urination, feeling tired, weak, appetite, nausea, vomiting, swelling, itching, drowsiness, dark discoloration of skin. So that's when you actually have some symptoms, but that's a very late stage. So what causes kidney disease, right? So what causes it? Well, to go over what causes it, I would like to bring up something interesting called the Pareto principle, right? Many of you in business may have heard this term before, the Pareto principle. It's the 80-20 rule, right? It was brought up by, I think, an Italian economist where he noticed certain trends that he noticed in crops where 20% of the crop seeds will wind up giving you 80% of your crop yields, right? Well, also that translates into business and other respects. Like 20% of your inputs result in 80% of your outputs, right? Or 20% of your customer base gives you 80% of your revenue, right? So, but this kind of translates over to medicine in a weird way, because if you look at it, here are the causes of kidney disease or things that injure the kidneys. And this is a list, but there's actually a lot more here. There's probably dozens more. But of this list, these two, diabetes and high blood pressure, result in a 65 to 70% of kidney disease in the country. So of all the possible diseases that can affect the kidney or traumas and issues that affect the kidney, diabetes and high blood pressure are the 2 largest by far, 65 to 70% of the problem in this country, okay? And the way I like to see it, maybe I'm the only one that sees it, I almost see our profession as two in one. One is kidney disease related to diabetes and high blood pressure, and the other, everything else and rare disease, right? So it's a weird dynamic that we have in nephrology.
Dr. Butt, in this case, that is untreated high blood pressure. Is that correct?
Well, yeah. So in this situation, unfortunately, so many people have poor screening or don't see their primary doctors early enough. So they'll have years of high blood pressure for so long. And same thing with the diabetes. They'll be sitting there for so long, or they'll know about it but not control it. Do you see what I'm saying? So diabetes and high blood pressure over time lead to kidney disease for sure. And this is U.S. renal data. This is where you can actually see that diabetes and high blood pressure are the 2 leading causes of end-stage kidney disease. About 65-70% of them that people on dialysis are because of those 2 diseases. Treatment option.
Dr. Butt, we have one other question here. If CKD causes hypertension and hypertension causes CKD, how do you know which is which?
It's both. So it's that vicious conundrum. It's that vicious conundrum that we have in nephrology. So high blood pressure can cause kidney disease, and kidney disease itself can cause high blood pressure. So sometimes you can't tell which one caused which, but oftentimes it can be, it can be either or, to be honest with you. But it's usually one, high blood pressure, diabetes leading to that. You see what I'm saying? So that's what we've seen. Now, treatment options for kidney disease is typically to treat the specific disease. So autoimmune diseases, lupus, all those diseases, but that's the 35%, right? For the rest of the population, for the most part, we're doing medication optimization, typically with medications called ACEs and ARBs, angiotensin receptor blockers, or ACE inhibitors. Those have been the treatment of choice for the last 15, 20 years. Now, there are some new agents that came to market in the last few years that we're trying to add, but quite honestly, for the last 15, 20 years, we use ACEs and ARBs. We also try to control diabetes and control high blood pressure. That's the main thing to prevent disease progression. And then we want to avoid nephrotoxic, or what we call kidney toxic medications. Okay, so certain medications, particularly what we call NSAIDs, non-steroid anti-inflammatory drugs, ibuprofen, Aleve, Advil, avoid those. So we're doing this kind of control, but this is essentially our game plan, and this is what we use to actually treat kidney disease when we have them in our clinics. So what happens when the kidneys fail, when you actually reach end-stage kidney disease? Well, there's several options at that point. When your kidney function gets to 15% or less, now typically at that point, you have enough kidney function there, but it's not enough to keep you alive or keep you in a good quality of life, right? So eventually, if you don't do anything, it will lead to death. Right, it will lead to death. Now, quite honestly, even in medicine, you may think as a doctor the worst thing you can see is death, but honestly, some of the worst things you can see is prolonged suffering. Right, so this is an ethical question that you have with dialysis, specifically with people that are 70, 75, 80 years old, multiple comorbidities. Do you put them on dialysis and subject them to further treatments and aggressive treatments, or do you let time pass and let them pass on their own? That's an ethical question, but oftentimes, I actually talk to my patients about, at certain stages in their life, maybe not doing it and considering palliative care. But again, that's a different discussion, but that's something perhaps that needs to be addressed in our profession. The other thing you can do once you reach end-stage kidney disease is do dialysis, right? And dialysis itself, and I'm going to go over the different modalities, but dialysis itself can be done in 3 ways. In-center hemodialysis, which is 3 times a week. I'll go over that. Home dialysis, which can be done at home. That you can do the blood dialysis, the home hemodialysis at home. And you can do peritoneal dialysis at home, which involves no blood, no needles at all. And I'm going to go over that. The other option is kidney transplant. Now, kidney transplant is utilized. You have options. You can get a living donor, typically your mother, sister, cousin, someone related to you donates a kidney to you, and you go on with your life. The other is the more common one is cadaver kidney. That means someone passed away and you get their kidney. Now, typically you could be on a waiting list for up to 5 years, depending on what state you're in. You're essentially waiting for someone to die and say a car accident that matches you, and then you get their kidney, right? Now, I'm not going to be talking about kidney transplant as much, just because I'm not a specialist in that as much. So in-center hemodialysis, okay? In-center hemodialysis occurs 3 times per week, 3 times per week. It's either Monday, Wednesday, Friday, or Tuesday, Thursday, Saturday, okay? Again, Monday, Wednesday, Friday, or Tuesday, Thursday, Saturday. Each session is 4 hours. And what they do on dialysis is they take the blood out of you, put it in a machine, clean it for you, then return it back to you. Again, 3 times a week, 4 hours each session. And in order to get access to that blood, you need to place needles in the arm into a fistula or graft, or have a catheter in your neck. And I'm about to show it to you. Now, this type of in-center dialysis is time consuming. You have to physically go to a dialysis center and stay there for 4 hours. Because of that 4-hour session, oftentimes it can be draining on people. They feel tired and weak afterwards. And sometimes it doesn't enable people to work because it could be at different times of the day, the set times of the day, not enabling you to get to work. Now, this is what an actual in-center hemodialysis actually looks like. This is a building that you have, nice little pretty building. On the inside, you can see 5 chairs set up with 5 machines. But quite honestly, these dialysis units can get huge. They can have 30, 40 of these chairs sitting in there, almost like a factory of dialysis, if you can imagine, where you have 3 to 4 shifts a day of 30 patients coming in over and over again repeatedly throughout the day. Then you alternate that with Monday, Wednesday, Friday, and Tuesday, Thursday, Saturday people. So it get to be large. Again, this is what an in-center hemodialysis looks like. And you can see that arm there. If you guys actually look closely at that person's arm, you see those lumps. That's an actual fistula. They actually stick needles directly into that fistula. One needle to take, two needles they put in there, one needle to take the blood out of you, another needle to put the blood back in after they clean it. How do they get that blood? Well, you have to create dialysis accesses, right? So this is, if you look at that gentleman's arm over there, you can see that those lumps is actually a vein. It's called a fistula. That's actually a natural vein that's been surgically altered to have more blood flow. You stick the two needles in there. Now, if you don't have the natural vein that's available for it, you can actually put a graft, that synthetic tube you can see right there, that little synthetic tube in there as well too. The fistulas are more optimal because they last longer. Now, if you don't have the access ready in the arm, because it oftentimes does take several weeks for these accesses in the arms to heal, you can have a catheter in the neck. And that's what a catheter actually looks like, okay? It has two ports on it, one to take the blood out of you, one to put the blood back in. These are not optimal. These are not optimal because they can get infected and have all sorts of issues. We typically want to leave them in for several weeks or maybe several months until the access in the arm is ready to go, okay? The other option is doing dialysis at home hemodialysis. Hemo means blood, so you can do home hemodialysis. Now, this occurs at a higher frequency. It's 5 times per week, but the sessions are a little shorter. They're 2 to 2.5 hours a session. The same thing, blood is taken out of you, put in a machine, clean for you, placed in arms of, needles are placed in your arms and your fistula or graft. But what the beauty is here, it's more flexible and gives the patient more autonomy because they can do those 2 hours whenever they want. And because it's only 2 hours, it's not as draining on people. And because they're getting dialysis every day, they feel healthier, their diets can be let up on, they actually have a better experience as a whole. The problem with the home hemodialysis, the blood dialysis, is a lot of practices and dialysis units may not allow you to do it at home unless you have a caregiver there to watch you, because blood is actively going to the machine, although I've heard some places they don't mind as much. As far as the market and the machines on the market, you can see on the left there, it's called the Next Stage machine. That's been a machine around, I think, for 10 or 15 years or so, a little bit older machine. Outset Medical is another a company here. They've designed a newer machine called a Tablo device. They were nice enough to invite me up to their headquarters in San Jose, I guess not too far from you guys. Got to see their device firsthand. It is a lot more user-friendly. It has like an iPad-like user interface at the top, very easy to use. And in fact, their setup is a lot easier. The Next Stage machine has around 30 to 40 steps for a patient to do before they set up the dialysis machine, whereas the Outset Medical device only has about 10 steps. So the usability is a lot easier and a lot more user-friendly. So a lot of people are actually adopting that machine. The other type of dialysis is peritoneal dialysis. Now, this involves no blood, no needles at all, okay? What you do here is you take a tube and you put that tube in your abdomen. Again, this is not going into an organ, it's going into the abdomen. And that tube just stays there. You take a big bag of fluid and you put that in that fluid, you take about 2 liters of that fluid and you put that in your abdomen. That fluid sits in your abdomen and that clean fluid goes in, it absorbs all the toxins using the endothelial lining of your organs in your abdomen. And it absorbs all the toxins, and then you, over the next few hours, just drain it out, okay? And those exchanges happen about 4 to 5 times a day, okay? I guess they pull out all the waste and excess fluid, and in this situation, there's no need for a caregiver at all, okay? This type of dialysis can be performed in 2 ways, manually, like you can see this lady here, clean bag of fluid up there, it goes in your body, and then, dirty fluid drained out at the end. The other form is more automated. It's actually a machine sitting by your bedside at night. All you do is plug yourself up to that machine at night. It pushes fluid in, pulls fluid out, pushes fluid in, pulls fluid out over the course of 8 hours, done at night while you sleep. So it's a very gentle form of dialysis. Again, very easy on the body. It's not as draining as, say, the in-center hemodialysis. This is what the catheter itself looks like in the person's abdomen, a little tiny little catheter there. These are the machines that we typically have. You have Baxter's machine, which is the Omnia. It's the newer machine. It actually is a very good user interface. It talks to you. Liberty machine is a little bit older machine. That's on the market. And the major players in the US market for dialysis, just so you guys know, are Fresenius and DaVita. Okay, those are their major players on the market. Okay, those 2 companies, as far as the dialysis world, control 80% of the US market. So effectively, we have a duopoly in kidney care as far as dialysis. Okay. As far as the U.S., they have DaVita has 2,800 brick and mortar centers, and Fresenius has about 2,500 brick and mortar centers. So these guys are major players in the market. There are other companies, Satellite, US Renal, other companies as well too. But they're like 1 to 5% of market share, and so not very much. And the other thing you should know, we talked about dialysis as a whole and the dominance of those companies, but also for a nephrology practice, and this is kind of an inside secret, I guess, if you weird way, but dialysis itself and dialysis units serve as major revenue streams to nephrology practices, right? I'm not, and so from a dialysis patient and a dialysis unit, a physician or physician practice can receive patient billing for visits. So when we see these patients on dialysis, when they're in a center, we see them 4 times a month. We bill directly to Medicare for those visits. You can be a medical director of those dialysis units that can get fees for it as well too. So just being a medical director, you get fees for that. You can go in and joint ventures. You can be part owner of these as well too. And there's typically a 51% share. So you get 49%, the dialysis provider gets 51%. So you get part owner of it as well. You can own the building as well too. So you get rent from it as well too. And also those dialysis accesses we talked about, and the fact that I'm an interventional nephrologist, and of those dialysis accesses actually have problems and routinely need ballooning, removal of clot, new catheters, all that stuff. So that's another revenue stream that's having if you have a vascular center, you can bill for that. So I'm not saying nephrology practices are greedy. I'm not saying dialysis providers are greedy, but the current model in that Medicare has set up has incentivized end-stage kidney disease as the cash cow. Right, as the cash cow. So it's not talking about prevention of kidney disease. It's not talking about decreasing the progression of kidney disease. You have incentivized dialysis as a whole as a cash cow for industry. So what's the result of this current model that we have? And the current model is in what we call the fee-for-service model. So you know what that means is essentially, if you see a patient in the hospital, you bill. If you see a patient in clinic, you bill. You see a patient on dialysis, you bill. You do a procedure on a patient, you bill. What fee-for-service does, it creates a model, incentivizes you to do more and see more. Right? It doesn't say for you to do more and see better or provide better quality or have better mortality rates. It just makes you want to do more for the patient, right? So that's the incentive model currently. And what that incentive model does is currently we have about 90% of our patients are doing dialysis in center. And I told you about all the benefits of doing dialysis at home for a patient, right? But because of the current model, 90% of dialysis is done in center. This has resulted in more hospitalizations, worse outcomes. As I mentioned before, late referrals to kidney for nephrologists. So they're not referred, they're referred closer to end stage as opposed to early on in the disease process. It's resulted in patients what we call crashing into dialysis. And what crashing onto dialysis means, you go to the ER sick and all of a sudden the ER doctor is telling you, hey, your kidneys aren't working anymore, you need dialysis. So a lot of, I believe it's like 60% of people crash onto dialysis. So it's a crazy amount of people in patients that crash onto dialysis. It's also developed an underutilization of kidney transplants as well too. So people are not getting as many kidney transplants or getting on the waiting list as much as they should.
We had a question on that and another one as well. Is it the case that there is not a shortage of kidneys?
There is, but they're working on. So I'm going to go over it in a second. But okay. There's an executive order on kidney health, and that's going to go into organ procurement and getting more organs and stuff like that. So there is a shortage. Don't get me wrong, and they're working on ways to better organ procurement and maybe even using other more kidneys than the more optimal kidneys to get people off dialysis. Do you see what I'm saying? So yeah. So they are working on that component. I wasn't going to address it as much because I'm not the expert in kidney transplant, but yes, they are working on that side as well too.
And then the other question is, you mentioned that home dialysis is better. I don't recall, what were the disadvantages of peritoneal dialysis? It seemed like it was the best choice.
Quite honestly, like I'll say this, if I were to, God forbid, need dialysis, I'd probably choose peritoneal dialysis. Okay, there are certain issues with peritoneal dialysis. One is you can't have pets at home, or you have to have a room clean of pets. So you can't have a pet like dog sleeping with you when you're doing this. You have to have an abdomen that hasn't had too many surgeries done to it. And the other thing with peritoneal dialysis is those exchanges using the membranes of the inner abdomen. Those membranes wear out after time. So there could be, those membranes can wear out. out over time. But in other places of the world, peritoneal dialysis is utilized a lot more. And from a cost perspective, peritoneal dialysis only costs about 50,000-60,000 a year versus 90,000 for in-center hemodialysis. Do you see what I'm saying? So there's a lot of benefits there, but there are some drawbacks to it as well too. I'm not saying that it's a perfect modality, but I think I would probably lean towards peritoneal dialysis as the first option for myself. So the other thing, so we were talking about Medicare, we're talking about the costs. Let me tell you about Medicare's interesting relationship with kidney care, right? So Medicare, as we know it, is an age qualifying insurance, right? So you turn 65 and you qualify for Medicare. We all know about that, right? But there is an exception to that. That exception is end-stage kidney disease, the diagnosis of end-stage kidney disease. Those people that are on dialysis qualify for Medicare. So you can be 30 or 40 years old and have Medicare, okay? That change was instituted by Richard Nixon in 1972. Signed into law at that time. But at that time, we only had about 10,000 individuals were receiving dialysis, 10,000. As of now, we have over 500,000 people in this country receiving dialysis, okay? And that's how much we have. And again, 90% of those are in center. Just looking at the cost perspective, those dialysis patients I just mentioned, those dialysis patients represent less than 1% of total Medicare beneficiaries, less than 1%, but they account for over 7% of Medicare's total cost, okay? So less than 1% of the population of Medicare dialysis patients account for over 7% of total Medicare spending, which is crazy. I'm going to throw this out there for you guys, just so you guys get a perspective of how much it costs. So hemodialysis, if we keep someone alive doing hemodialysis in center, how much do y'all think it costs? Just going to throw it out there. Okay. Is it 5,000, 10,000 a year? No. Okay. I'm just going to tell you it's 90,000 a year. 90,000 a year to keep someone alive on in-center hemodialysis a year. Okay. But the cost of a transplant and maintaining a transplant, and that's all the drugs that are needed, the immunosuppressive drugs and all that stuff, is 34,000. Okay. So there's a huge cost differential there. So we should clearly be doing one over the other, right? Or emphasizing one over the other.
We have a question.
Yeah.
What is the 5-year survival rate for ESKD?
Oh, yeah. So the average lifespan of a dialysis patient is about 5 years, or so. But the thing is, it depends on the age, right? It depends on the age. So if you're 70 years old and you're going on to dialysis, chances are, what are you going to live? Like 2 years, 1 year or something like that. But if you're a 40-year-old going on it, you're going to live longer, right? So it's an average. It's not really there. So yeah. So there is that, but that average has to be taken into account for individuals, right? So, so the current makeup of the dialysis community, as far as in-center versus home versus transplant, well, it's not going to work, right? The status quo does not work. So it's time to change this up, right? It's time to change this up at this point, right? So what happened was in 2019, in July of 2019, President Trump signed an executive order on kidney health. It's called the Advancing American Kidney Health Executive Order. This is how I got involved in value-based medicine. I was asked to present about this executive order. I've actually read an executive order and combed the CMS websites, the two most painful things I've ever done, but whatever, I've done it. But this order itself was brought to us not by President Trump himself, but the Secretary of Health and Human Services, Alex Azar. Secretary Azar is a really interesting guy because he actually had a father that had end-stage kidney disease. His dad was on in-center hemodialysis, then actually went to peritoneal dialysis, then actually got a kidney transplant. So Alex Azar has seen the entire spectrum of kidney health in America. So he wanted to come up with a bold new plan, a system that pays for kidney health rather than kidney sickness. Okay, the system pays kidney health rather than kidney sickness. So why do we need this new law? Why do we need this law? One, because nephrologists suck, and two, because Trump hates nephrologists. Right? It's clear the man hates us. Right? Just kidding. Biden hates us too because he's doing the same thing to us. So, but anyway, the three goals of the executive order are: by 2025, have 80% of new end-stage kidney disease patients start dialysis at home or get a preemptive transplant. Okay, let me rephrase that. Okay, 80% after 2025, 80% of the people that are diagnosed with end-stage kidney disease, they want those people to do dialysis at home or get a preemptive transplant, not just do in-center dialysis. Okay. by 2030, reduce the incidence of ESRD by 25%. That's a pretty bold plan. By 2030, double the number of kidneys available for transplant. Brian, that goes to your question you just brought up. That's a part of the executive order. I'm not as familiar with that component, but they are trying to increase organ procurement as well. And they're actually trying to incentivize living donors, so getting living donors to volunteer to donate. So how do you do this? How do you implement this kind of these goals, right? How do you do that? Well, you got to change the incentive structure, right? So in this executive order, they came up with 3 new value-based medicine kidney models. These are kidney care models. I'm not going to go over them in detail, guys. And if whoever here is really wants to know the details, I have done lectures on this. I have it on my YouTube channel, so where you can see a full-on nitty-gritty about the models. But I want you guys to take away major points of where they're incentivizing these models. Okay, so you have the ETC model, the KCF model, and the CKCC. The big difference between these models, the ETC is on one side, the other two are the KCF and the CKCC. And the big difference is the ETC is mandatory. Okay, CMS has selected 30% of the country to be a part of it. Doctors and dialysis units to be a part of it. So they're automatically in. The other 2 models are actually voluntary, so you actually have to volunteer to get into them as a practice, as a dialysis unit, whatever it is. The other thing is the ETC model is just involving dialysis patients, the end-stage kidney disease patients, whereas the KCF and CKCC involve dialysis patients, but also people with kidney disease stage 4 and 5. Okay, stage 4 and 5. So the Medicare is not only getting the management of dialysis, they're getting into the management of kidney disease itself and trying to slow down the progression. So they're getting into that business. The mandatory model, again, the ETC, just so you know, it's supposed to give financial incentives to pursue home dialysis and kidney transplant. It's going to run from Jan 1, 2021 to June 30th, 2027. It's mandatory. CMS has already selected the participants, 30% of all facilities and doctors. How will CMS get you to refer your patients for transplant and do home dialysis? By giving you 2 adjustments. One is a home dialysis payment adjustment, which would increase the payment for home dialysis. That's it. Over 3 years, that is going to increase the dialysis, the reimbursement for home dialysis. But they're also going to do what they call a performance payment adjustment. This is interesting because what they're doing is giving you they're essentially creating a point system and awarding points based on your home dialysis rate and your transplant rate. Okay, home dialysis rate and your transplant rate. So you're going to get a score essentially and be compared to other people in your geographic area. And in this model, the nephrologist can get a 4 to 8% bonus, but they can also get a penalty of 5 to 9% on their payments. Okay, and the dialysis unit, same thing. They get a bonus of 4 to 8%, but they get a penalty of 5 to 10%. So guess what? This creates downside risk, right? So downside risk for doctors and dialysis units to actually have results regarding home dialysis and transplant. The other 2 models, the voluntary models, again, these models again involve not only dialysis patients, but kidney disease stage 4 and 5 patients. It runs from Jan 1, 2020 to December 31st, 2025. But they changed it up. So this is not as fee for service. Okay. Remember we talked about fee for service, right? When you see a patient in clinic, you get paid. When you see a patient in procedure, you get paid when you do more things. Instead, they're going to do what they call a capitated payment, meaning you get a fixed sum, either monthly or quarterly, for patient care. So that patient's on your roster, you get a fixed payment irrespective of how many times you see them. Okay. Now, a capitated payment is what we call the adjusted monthly capitated payment for dialysis patients. That already exists. We see them on dialysis. What they do in this capitated payment is they increase the home dialysis payment to equal the in-center payment. So before, the home dialysis payment was lower. Now they kind of equalize it. So they say hey, the home dialysis pays you just as much. Okay. Then the next capitated payment is actually what they call the CKD quarterly capitated payment. Okay. So typically when I see a patient in clinic, I see them once a month, once every 4 months, whatever it is, I bill when I see them, right? In this situation, they get rid of that. They pay you quarterly for the management of that patient. That's it. You get a quarterly payment. You can see them every month. You can see them twice a year. Irrespective, you're responsible for that patient, right? And every year that patient can be adjusted accordingly up or down depending on your results, right? Now you're saying, why would I do that? Well, What's interesting is in this model, these capitated payments are a continuous revenue stream for a practice, right? As opposed to having the ups and downs of billing occasionally month to month or whatever it is, if you're getting a continuous revenue stream quarterly, that kind of incentivizes you to, and you have a continuous revenue stream. It actually does help your bank account, right? In a weird way. So they're trying to incentivize you there. And lastly, and this goes to what Brian brought up about transplant as well too. This is one is huge. The last one is the capitated payment is a transplant bonus. So if you get your patient a kidney transplant from CMS, you will get paid $15,000 to the physician. $15,000. Okay. So $15,000 will go to the physician if you get them a kidney transplant. And in these models, if you go into these models. Now that $15,000 is allocated over 3 years. Year one is $2,500. Year two is $5,000. And year three is $7,500. Again, allocated over 3 years. And it's meant to keep you involved and keep that kidney going, because there is a point of kidney rejection and all this other stuff and better management that they want you to be involved in the care of that patient. But that's a pretty big chunk of change, $15,000 to a practice, right, for a patient. But if you think about the sheer cost of dialysis and keeping that patient on dialysis, which is $90,000, it's a drop in the bucket, right? It's a drop in the bucket. What's the point of these value-based kidney disease payment models? Is to create incentives for patients, for healthcare providers to do preemptive transplants, meaning get them transplants before they need dialysis. Move beneficiaries along the transplant process, and improve the transition to dialysis, right? Avoid hospitalizations, make that transition to dialysis nice and easy. And lastly, and I think this is the most important thing, guys, this is the most important thing, CMS wants to demonstrate whether kidney disease can be delayed by these models interventions. So they want to not only want to pay you differently, but they want to see if they can slow down the progression of kidney disease to make maybe avoid or delay dialysis as much as possible. Think about if you just delayed dialysis for 6 months or a year, that saved Medicare $90,000. That's huge, right? Now, where do I see innovation in kidney care? Is it in pills, more pharmaceuticals, new devices or procedures, new dialysis machines? That's the Quanta dialysis machine, by the way, or an artificial kidney. Yes, I see innovation there, but the main innovation I see, and I think is the most impactful, is in healthcare delivery, clinical care coordination, and decreasing the cost of kidney care. I think those are the key places to make the most change. Okay.
A couple of questions, Dr. Butt.
Yeah.
These are, the first is, are medical schools encouraging MDs to go into primary care to include kidney labs as part of annual physicals and labs for their patients? And being somebody of advanced age, I will generalize the question and say, what should I expect my doctor to do for me every year when I go see him?
So quite honestly, like kidney labs are checked routinely on everybody. So when you get your electrolytes checked, it has your BUN, creatinine, and EGFR on there. So your primary doctor is checking it. The inherent problem we've had for decades is a lot of the older physicians, like they only refer when the kidney disease is late, right? So when the GFR is less than 30, or when the percentage is less than 30, they're like, okay, now you go see a kidney doctor. Do you see what I'm saying? Yeah. Things are changing from that perspective. But that's something you guys can routinely do on your own. Is just ask about what's my GFR, and you can know what your kidney function is like, or just ask how are my kidneys doing on percentage of kidney function. So
very good. And then the second question is, what is the rate of successful transplant, and what is the typical length of time without rejection?
Ooh, that's a hard question. I'm not a transplant guy, so I don't want to answer that. I don't know exactly the exact numbers as far as that. Sorry. So
no problem. Thank you.
Yeah. Anyway, so what I was getting at, so I think innovation is really in the healthcare delivery, clinical care coordination, and decreasing cost of healthcare. Quite honestly, let's just say we don't have any new technology. Even the current technology or the current medication regimens we have, I don't think they're optimizing those properly anyway. So if we can coordinate care better, that in itself could be an innovation and improving that. And if you have a device or a pill or whatever, approaching it in a value-based medicine way, saying, hey, this is going to decrease hospitalizations to, say, an insurance provider or a health system, is going to have a really good effect. I know in the device world, you're always trying to get your CPT code or billing code or whatever, but imagine if you can just go to a health system and say, hey, I'm going to save you 5 days of a hospitalization with my device. So this is how I can design the price point. So as far as the value-based medicine and innovation in healthcare delivery, these are the new players. I know you guys are into startups, but these are the big players in the kidney care value-based medicine space. Strive, Somatis, Cricket Health, and Monogram Health. They're all in value-based medicine and kidney care. And just so you get a breadth of what's going on, I've never seen so much money going to kidney care, but Strive raised 140 million in their Series B. Somatis raised 64 million in their Series C. Cricket raised 83 million in their Series B. Monogram raised 160 million in their Series B. This is all, I think, in the last 2 years. So kidney care is hot right now as far as managing it better and all that kind of stuff. Now, those are the new players. The old players want a piece of it too. The DaVita, the duopoly we talked about, DaVita and Fresenius, they're creating their own value-based medicine divisions, okay, to actually manage patients better as well too. So what does value-based, how does value-based work? We've heard this term, it's kind of a catch-all right now, but value-based, how does it work? Well, one is these startups that we just talked about. They're going to help implement those kidney care models of CMS wants in place, right? So individual physician practices really can't implement those models themselves because it's too difficult logistically, right? So they're helping doing that. But they're also talking to commercial insurances as well. They're literally these startups are going up to the Blue Cross, Blue Shields, United, and say, hey, give us your kidney disease patients, your most expensive patients, and we'll manage them better. And whatever money we save you, we get to keep a part of that. So that's how these models are working. So it's no longer fee for service in that sense. They're going after capitated payments from those insurance providers. And what these startups are doing is assuming risk, meaning are responsible for the total cost of the patient. And they make money if they save the insurance company money. So that's how they're approaching it. And they're doing it by coordinating care, literally having what we call clinical care teams. Those clinical care teams will have a doctor, but it'll also have a nurse practitioner, a dietitian, a social worker, and sometimes even an in-field nurse that goes to the house and checks up on the patient and all that stuff. And in the fee-for-service model, that doesn't work because there's no reimbursement for some of that stuff. But in the value-based model where you're trying to save money, it does. They also are trying to recognize and diagnose kidney disease early. They're slowing the progression of kidney disease through optimizing care. And they're using AI and ML to do that. They literally use AI and ML to comb through patients' charts and billing codes to literally detect who is at risk for kidney disease and who is at risk for kidney disease progression, meaning whose kidney disease is going to progress faster than others, right? They're also incentivizing kidney transplants and home dialysis as well. I've heard them having their own transplant bonuses as well in their models too. The main takeaway I would say is you were talking about doing dialysis at home, but I think overall what we were seeing in general in a trend in America, and this has been COVID has been an accelerant of this, is bringing it all home, right? With things like telehealth and remote patient monitoring. Telehealth pre-COVID remained underutilized, lacked reimbursements, limited to rural areas. But March 6th of 2020, CMS expanded Medicare coverage and an emergency declaration. You had a rapid uptake in the pandemic. And during that time, Medicare's primary care visits were only 0.1% telehealth in February of 2020, rapidly increased to 43% in April of 2020. Overall increased by 50% since that time. It's true for the private sector as well. Outside of Medicare, 96% of large self-insured employers intend to offer virtual health services by 2023. You have over 100 independent telehealth organizations at this point. Some of them have the breadth and scope of traditional healthcare systems. They have all their specialists on these virtual platforms now. You have the recent merger of Teladoc and Livongo. Remote patient monitoring. What I like about remote patient monitoring is that it really gives me a whole picture of a patient, right? So a patient comes to me in clinic, I get a snapshot of them, right? I get a blood pressure at that time. I get, symptoms at that time. And oftentimes the patient can come to me and be nervous just seeing me. It's called white coat hypertension and raise their blood pressure. So by giving me continuous readings over hours or days or weeks, I really get a sense of how their diabetes is doing, how their high blood pressure is doing. And that gives me a better sense there. So again, you get a more constant stream of data, clearer picture of the patient's health.
Dr. Butt, in that context, a question here: is there a need for innovations for better monitoring of hemodialysis? That is, to know when a dialysis session has achieved its goals.
Yeah, as far as remote patient monitoring, you're saying, is that right? Or just in general?
Yeah, either in situ or remote. Yeah.
Yeah. So we do have labs. It's called a URR. So we take a urea before and after as a calculation, and we want to a certain amount removed, 70%, to say, hey, that's going. But yeah, that is definitely a need. The whole thing is to convince the nephrology community that biomarker or clearance that you came up with is accurate and as accurate as the current standard, right? So yeah, absolutely. If you can remotely tell me that every dialysis session you're cleaning this much, that'd be really, really beneficial for sure.
We have another one similarly. A GFR test, that is a direct test of glomerular filtration, sorry, is not inexpensive. Is there another biomarker in the works, or could you envision a biomarker research that could be suggestive of kidney disease, that could be potentially affordable and put on a standard, that annual blood test panel, and then drive referrals to direct GFR test?
Yeah, no, there are some in the works, I believe so. I forgot the name of it, but there is one in the works particularly. Some issues with the creatinine is that it can vary a lot, meaning creatinine is based off of muscle mass and the return of muscle mass. So certain races have more than others. If you're taller, you have more creatinine than a shorter person. Females have less than males. So there's all this subjectivity to the creatinine. And in fact, what's a funny thing about creatinine is if you take the supplement creatine, and I've had several patients take the supplement creatine, it turns into creatinine, artificially making your blood look like you have worse kidney disease. So yeah, so there are others I believe others in the works right now as a better biomarker for kidney health. It's just for the last, 30 years, 40 years, we use that as a marker. And for the most part, it's pretty accurate, don't get me wrong, but it'd be nice to know if there's others out there that are more individualized, right? That don't have to be extrapolated as much, I guess. So, but yeah. Anyway, as far as remotely monitoring, currently CMS does let you bill for blood pressure monitoring, blood glucose, weight, and spirometry, which is pulse ox. The devices are typically either cellular or Bluetooth. Benefits of remote patient monitoring: keeps people healthy, older people live longer at home, avoid nursing homes. Nursing homes can be really expensive, skilled nursing facilities, reduce hospitalizations, lengths of stay, improve quality of life. And the things I just brought up kind of go along with the scientific roles I have currently with Aleo and Icona Health. So Icona is actually a virtual kidney disease education platform and digital platform. You can educate patients both on kidney disease and dialysis as well. You have the assistance of a virtual coach, which is awesome. A physician dashboard to see your patient's progress, so you can see how much they're retaining, which is pretty cool. They have virtual reality headsets that actually can train you how to do dialysis at home. That's a novel approach as well too. They can cover topics about kidney disease, diet, transplant, home dialysis, all the stuff that doctors don't have the time for to discuss in their clinics. That this can be done remotely. And then, of course, Aleo, the hometown favorite here, that was incubated right here. It's a smart patch. It's actually placed over those fistulas and grafts we talked about, and it remotely and non-invasively continuously monitors potassium, hematocrit, blood pressure, pulse ox, your fluid status, and actually develops those issues I told you that develop in fistulas that are narrowings and tightenings. It can actually detect that early. And goes along with what you said about, monitoring people on dialysis. This is something that can do that as well too. And they have a good clinician portal as well. Anyway, that's my presentation. I would love to field any questions, any more that you guys have.
Thank you very much, Dr. Butt. This is terrific, especially CKD is in my family, so this is all user manual stuff for me.
Oh, that's cool.
Yep. And I have one more question thus far remaining, which is very much for us grant writers. What are the NIH, NIDDK, and NIBIB doing? What are their roles? Any incentives or grants that you're aware of?
Ooh, I don't know, but I know that a part of the Trump executive order on kidney health, there were some in there. Do you see what I'm saying? So I definitely know right now, it's not just VC money that's going after this. There is NIH, and then you have, oh my God, what they call the Kidney X, American Society of Nephrology is partnered with CMS. They have some grants available through the Kidney X program for new technologies coming out as well too.
Thank you. Another question here is my sister recently was in the ICU due to kidney failure caused by a long-term battle with lupus. Is she not an ideal candidate for transplant?
No, not at all. No, she should be so transplant candidacy is really fascinating. Age is not a absolute factor, but it can be thrown in there. I don't know how old his sister is, but yeah, but other things go into it. So lupus itself is not a disqualifier of needing getting a transplant. And in fact, a lot of the autoimmune medications that you may need for lupus because it's autoimmune disease are given to you when you're on transplant anyway, right? So it's a weird kind of thing. But at the same time, it depends if she's in the ICU, how long she's been out. So it takes some time. So they're not going to just transplant anybody, right? They want to make sure you're healthy enough to receive a transplant. So they may need you far along from the hospitalization. How far is she in recovery? Is she ambulatory? Is she walking around? Is she breathing okay? All these other things. So they're not just going to throw a transplant in somebody. They're going to have to evaluate her. But just having lupus and being in the ICU shouldn't be a disqualifier, but they're going to have to take the whole person into account.
So I've actually accumulated a whole bunch of questions here at the end, which is nominally our habit, but it is 1 o'clock, so I don't want people to need to stay if they have to do something, but we'll keep at it here for a few more minutes.
Sure, I got time, by the way. Go ahead.
Thank you very much. What is the status of artificial kidneys?
Ooh, that's a good question. So I've actually got to talk to Shuvo Roy. He's over at UCF. I talked to him about a year ago. I want to say he said about 10 to 15 years out. That's what he says. But the way I think about it though is like, it's not like we go from current technology to artificial kidney, right? I look at it as like you saw the Tableau device, right? I look at it as the continuing improvements in current dialysis to miniaturizing those technologies and miniaturizing them, then eventually going to wearable and then going to implantable and kidney, right? So I don't think you have to just jump to artificial kidney. I think you're going to see improvements along the way, and when you see those improvements, it'll eventually lead to an artificial kidney as well too. So that's how I think of it. But the interesting thing is that I know people are like, artificial kidney is going to solve the problem, right? I'm like, that's why I'm more in the value-based medicine space, because I really feel like, I don't want an artificial kidney. I want my doctor to take care of my kidney, so I don't need an artificial kidney, right? And just like I don't want a better dialysis machine, I want to stay off dialysis, right? So that's where I really feel that innovation and improvements can really be made to prevent that eventual need for that kind of the device.
Excellent, thank you. Here's another one. Medicare pays for RPM, and I forgot what RPM is.
Yeah, remote patient monitoring. Yeah.
Okay, thank you. But can you clarify if they pay for it at stage 5, or is there any RPM stage that cannot bill? In other words, can you?
Ooh, that's a good question. That's a really good question. So I know they pay for those current things, and I think the reimbursement can be, I don't know, 120 to 160 a month or something, depending on how you're doing it. I didn't think there's a disqualifier as far as other diseases, right? I couldn't imagine them not saying a dialysis patient or a certain kidney disease patient doesn't qualify for RPM, because those are the people that really need it. So I'm not aware of that from what I see, but yeah.
Very good, thank you. Here's a fairly general question. Could you comment on the differential economics of home and center-based dialysis approaches?
Repeat that one more time.
What is the difference in economics between a dialysis center-based care versus home-based care?
Oh, okay. So as far as reimbursements, as far as so dialysis at home does make sense from a physician standpoint as well too. Because the reimbursements are actually higher, and even for the dialysis provider, they get reimbursed more as well too. But I think just I oftentimes don't just think everything is nefarious or malicious. I think it's just groupthink. And so it's easier, the economies of scale, they've just pushed people into dialysis units and pushed them in there. So the economies now do make sense. There are, as you can see in my presentation, they are increasing payments for home dialysis and everything. So the economics does make sense. It's just the mindset change. And to be honest with you, I think a lot of times we underestimate what we can make our patients do. Do you see what I'm saying? Meaning like we think, oh, they're not smart enough to do dialysis at home, right? So now we should, now we're being pushed to educate more and try to get them to do dialysis at home. So I think that's that's going to be the key, is this change in mindset of nephrologists and nephrology programs, but also dialysis units to encourage more patients to do that. You generally do see that, at least in my practice, but yeah.
I was going to say that medication adherence is notoriously bad, of course, but do you find that home dialysis patients are compliant? That is to say, they are diligent in their dialysis.
So yes, home dialysis patients are pretty good. Okay, so there is, but you start to wonder in your head, because the numbers are better. So if you do dialysis at home, chances are you're going to live longer. You're going to have less hospitalizations. You're going to have a better quality of life. You're going to feel better overall because of daily dialysis and all this other stuff. And oftentimes, I think there's kind of a selection bias. So we pick the best patients to do home dialysis, right? We pick the accountant, the lawyer, someone that does something for a living. And so that person gets to go on dialysis. We have these awesome results. So there is kind of a selection bias there currently, and that's perhaps leaning towards the good numbers that we see. But at the same time, I think once, and I've put in a lot of people on home dialysis, particularly peritoneal dialysis, that you wouldn't think could do it, and they have better results. And I think most people only play up to their own, to the competition, right? So if you just put them in the center, put their arm out and they stick needles, they're just going to sit there and do nothing. But if you actually challenge them to actually do dialysis at home, they will actually do better. They will do better. And there's a lot of this. I think it's grossly underutilized. Do I agree with the numbers of 80% at home and parenteral transfer? Probably not, but 10% it's not there. I would say closer to 30-40% probably could do dialysis at home if we pushed them and the technology was easier, and the user interface was better and everything. So I think it's still grossly underutilized. And I totally forgot the actual question, but
actually, so did I. Sorry. A question. Any information on the recent pig kidney transplant that was successful?
I knew I should have read up on that one. I knew I got the email and like the notice from my practice, and I was like, I got to read up on this. I totally forgot to read on it, but I think it was pretty promising. I just hope they come out with a more kosher version of it. I'm just joking. I'm Muslim, so I'm just joking. I'd take a kidney, pig's kidney, but whatever. But yeah.
And here's perhaps a good question to end on. What are the most important things we can do to keep our kidneys healthy?
Oh, that's a good question. I mean, so the way I always shape it to people, the kidneys are the canary in the coal mine, right? So they are literally affected by your whole body. So it's not one thing. I think everybody wants that one thing, that's magic bullet kind of mentality. Like, oh, I got to take cranberry juice. Oh, I got to drink a lot of water. Yes, drink a lot of water is good. But if you take care of yourself as a person, prevent yourself from getting diabetes, high blood pressure, walk, exercise, all that kind of stuff, that in turn will take care of your kidney health. Particularly, we're talking about the most common reasons, right? The 65-70% of people with kidney disease, that's preventable, right? That's preventable if by lifestyle and diet modification. So generally, that's how I would do it. And of course, drinking more water would help too.
Very good. I think we're out of time here. Everybody's being yelled at by their boss by now. So I just want to thank you so much, Dr. Butt, for a terrific presentation, both on the highly advanced speculative side, but also on the very practical side. I appreciate it. As I say, it's the diseases in my family, so this is very, very hands-on stuff. Thank you very much for coming.
Thank you. I really enjoyed having you.
Thank you all for attending. We check back this space, and we will let you know when our next presentation is coming. And otherwise, have a good afternoon or evening, depending upon your time zone. Thank you.